So I'm Sherry Weinberg, and I'm the President, Physicians for a National Health Program, Washington. We are working very hard on expanding from Western Washington to the whole state. But we're still mostly in Western Washington, although now tonight we've got even somebody from New York joining us. Yay! Tonight we gathered together to listen to and get a discussion going with Dr. John Geyman. He is an emeritus professor from the University of Washington School of Medicine, Department of Family Practice. And mostly since his retirement, he's been writing a lot of books, one a year or more for several years. He has also he's an honorary chair of our chapter, and he has also been, is a past president of Physicians for National Program, the national organization. He now lives in Friday Harbor. And the one thing he hasn't retired from is flying an airplane. Still flying, right?
Yes, 61 years.
61 years of flying. Wow. David Himmelstein made this comment about the latest book, America's Mighty Medical Industrial Complex. Quote, the best guide to the corporate-driven corruption that has overtaken healthcare and how the search for profit elbowed aside medical ethics and the best traditions of the medical profession. And I couldn't echo that sentiment more, that this is what we, as the physicians among us, really feel the loss of that professional ethical obligation to our patients and the relationship between the physician and the patient. But I won't go on more. I will turn it over to Dr. Geyman.
Well, glad to be with you. My Zoom consultant is Emily here. And in case we have tech problems, she will be at my side. Anyhow, I'm glad to be with you and with fellow advocates and spirits. The 60-year thing is, let me digress a little bit. I'm 61 years out of medical school at UC San Francisco, and we have virtual reunions now and via Zoom again. But anyhow, each reunion, all of the participants to a person have the same sentiments that I think I'm hearing in this group. The citizen has gone really bad and corporate and taken over from us. And where is medicine as it should be practiced in healthcare? So with that, I wanted to do this, in effect, a 60-year view of our system. And so this book it's got 3 parts, historical background, and I go through the early traditions of medicine before it was transformed, and then the rise of the medical industrial complex and business versus service ethic and all like that. And then part 2 is where has the medical industrial complex taken us? And that goes pretty bad. And I had to have fun with the mighty medical industrial complex. See? So, and then the 3rd part is healthcare reform possible. And before I start, I wanted to mention several people. Dr. Pellegrino, many of us know in medicine. He was a physician and an ethicist and a moral philosopher, and for many years ran the advanced study for ethics at Georgetown. And here's what he had to say about medicine. It's at heart of moral enterprise, and those who practice it are de facto members of a moral community. We can accept or repudiate that fact, but we cannot ignore it or absolve ourselves of the moral consequences of our choice. We're not a guild, we're not a business, we're not a trade union or a political party. If the care of the sick is increasingly treated as a commodity, an investment opportunity, a bureaucrat's power trip, or a political trading chip, the profession bears a part of the responsibility. So that's way back there. And all that's happened. So now I want to mention one other person to whom I dedicate the book. And this is Arnold Relman. He was editor for 13 years of the New England Journal, general internist, long advocate of the ethical base of what we do. And here's what he said. He wrote a paper in New England Journal in 1980, the first person in medicine to call it a medical industrial complex. Here's what he said. If we are to live comfortably with the new medical industrial complex, we must put our priorities together. The needs of patients and of society come first. How best to ensure that the medical industrial complex serves the interests of patients first and of its stockholders second will have to be the responsibility of the medical profession and an informed public. So what date it is and where we are. So on to the next. These are transformational changes. They really have transformed healthcare since the 60s. So, and the book goes into all this in detail, but corporatization is big. Shift to for-profit care is huge. We know that healthcare services have been commodified as a thing to make money on, and growth of medical industrial complex. That goes back to what Eisenhower warned us about the military industrial complex way back in his farewell address to Congress when he left. And then increased investor-owned care, and I'll come back to that in a minute. That's just amazingly bigger than I thought before writing this book. And then increasing privatization, including Medicare and Medicaid. And as you see every day on Medicare ads for Medicare Advantage, which I call Medicare Disadvantage. You see Joe Namath up there. But the next slide will be the for-profit thing. And the numbers there are bigger on that slide than most of us might have guessed. 2/3 of nursing homes are for-profit. Many are in nursing home chains. We had one example up here on San Juan Island. We're the only nursing home in our county of a bunch of islands and 17,000 people when they came. And it was closed with 3 weeks notice to patients and staff, and they just left. But it was part of one of these big national chains. Laboratory and imaging, as I recall, is 100%. A lot of them are up above 80%. Dialysis is 90%. Home care is 76%. Hospice is 2/3. Anyhow, it's much more common to be for-profit throughout our system now than you might have guessed. So next slide. And we all know this. Look at this, though. Isn't that stark? And this is David Himmelstein and Steffi Wohlhandler's work way back a bunch of years. As you know, they pretty much started PNHP way back in 89 or so and 90. But they've done such good work all along. But look at this 30-year story about managers and physicians. And that fits with physicians no longer running their own practice, which Dale did for many years in Bellingham in pediatrics. But now increasingly they're hired by mostly hospital systems. And now, as the book will go into, this private equity is a terrible trend, and these private equity things out of firms out of Wall Street and that, they'll buy up dermatology practices, ophthalmology practices, and several other specialties at a great rate. And each time physicians have to go to work for some kind of a hospital system where their employees. Let's look at what happens when we go to investor-owned care. And I have this in my book, and this is totally documented from top to bottom. David Himmelstein and Steffi have done a lot of that work, like in HMOs and hospitals. But the story is always the same. They come in investor-owned. The costs go up to patients. They cut staff. The quality of care goes way down. EMS, higher prices, worse care with slower response times. HMOs, worse scores, all quality of care measures. Nursing homes, we've talked about that a little bit. Mental health centers, bad again, including premature discharge without adequate outpatient care. Dialysis, mortality rates higher, and you won't get on a transplant waiting list very often there. Assisted living, it's even bad there. Home health, same deal. Hospice, same deal. There was a physician up in Alaska who was in a for-profit hospice. They wouldn't even come and see him in his last few days. This is instructive in primary care, which should be the foundation of our healthcare system, but no way. It's been undervalued and underinvested in, and undervaluation of our primary care services. The financing system is procedurally oriented, as we know, and not intensive time evaluative care, which precedes treatment, such as in the primary care fields, and including geriatrics and including psychiatry. We don't have any system in this country for physician workforce planning. In England, it's 50% general practice is the base of the system. In Canada, it's something like 40, 35 or 40. Here, we just don't have a system. And I can say that it's less than 10% of medical graduates go into family medicine. And a big majority of general internists and general pediatrics go into subspecialties. And then the financing system for graduate medical education is a problem. And the for-profit ethic is a problem. And increased corporatization within the medical industrial complex, we've mentioned that. And growth of investor-owned care. This gets to the frustration of being a physician nowadays. You recall that slide about the growth of administrators and managers. Well, this is all about the billing process, and this is 3 years old, 4 years old now. This is how much the electronic record requires in desk work, and it's cut down the time with patients immensely. We have a little story of a friend of Emily's who is in a small town on the Oregon coast, and she went to her doctor. They rotate through there and come and go, but she went to a physician who spent all of the entire visit on the computer, and she asked him at the end, "What color are my eyes?" That set him way back, and he couldn't answer, of course. But anyhow, this is a big deal, and this is part of the burnout of physicians. Here's the burnout, which is kind of interesting. Look at the age differences. If you start with millennials, they burn out much more quickly, and look, over half of them are burned out already, and too many hours at work and like that, and lack of respect from administrators, employers, and colleagues or staff. But then come back down to increasing computerization. They don't mind that, but look at the older ones. The boomers don't like that at all that increased computerization thing. So it's all related. So next slide. Well, going to patients now, we talk about unaffordability of care, but this says a lot. Here's a 40-year view versus the CPI for medical costs. And it keeps going on up, as we know so well. And next slide. And then so we have this theory that at least the GOP has a theory that if you just have patients have more skin in the game, that they will be more prudent in the kind of care they want. You know this whole story. So, but hence these deductibles that get higher and higher, and look across there, the more you raise those office visits, it reduces office visits and emergency care and mental health and imaging procedures and on and on. So next slide. We've talked about healthcare reform for a long time. In the Clinton administration, they had these meetings in the southern states and brought all the stakeholders together and what should we do? And you know, that didn't solve much. Then the most recent in 2008 and 9, of course, the Affordable Care Act. And again, it's pretty much, we turn to stakeholders who create the problems, and that doesn't work. And strong presidential leadership is needed throughout the whole process. Obama said he was in favor of single payer when he was running for Congress and out of Illinois. Then he forgot those two words. Corporate power in our medical industrial complex is huge. They'll lobby up and they'll put 5 lobbyists in DC and the Beltway for every member of Congress. And then the more complex a bill gets, the more its legislative and public support erodes. We should remember about that now. And then how the issues are framed, it's always been inadequate, and our opponents are better at it than we are. And the opponents use fear mongering and disinformation to distort the debate. You know, national health insurance or Medicare for all would be a socialist plot, on and on and on. We couldn't afford it, blah, blah, blah. And then the mainstream media have more conflicts of interest closely tied to corporate stakeholders than we might expect. And Emily and I have been trying to get the word out to the major networks in New York City, and that is one big firewall. We never get anywhere here. And then history repeats itself, and we just don't learn from our mistakes. So failed ideologies, well, consumer-driven healthcare, skin in the game, it doesn't work. We've done that for a lot of years now, and look at the problems we've got. And then everyone gets care anyway. Some people on the right think that, but no, we ration care big time. And people forego care a lot. They have worse outcomes. But the opponents won't admit that we ration care and say that if we got national health insurance, we would ration care, and Sarah Palin's death panels, remember. So then there's this meme that the private sector is more efficient and can fix system problems better than the public sector. That's just a total way off the wall. And our opponents talk about taxes, of course, but here's this group of PNHP people down at UC Berkeley, Saves and Zuckman, and this is their work here back 110 years. is looking at our tax rates for the top 0.1% versus the bottom 90%. And look at that. I mean, a lot of years, the majority of the years, the top 1.1% paid way up, even as high as 50 and 60%. And now they complain about 21% or versus 27, or no way would they get 35, you know. So this is useful to know. Next slide. Well, here's why this is a really bad thing that has happened to healthcare in our country, and it goes back to Richmond shipbuilding and during World War II, and you needed a healthy workforce. Many are off at war, and so you need healthy. So Kaiser and others set up employer-sponsored health insurance, and we've had it ever since. But the problem is now it's increasing costs for both employers and employees. There's a growing feeling among large employers that they can't afford to keep this going more than another 5 or maybe max 10 years. And the benefits keep diminishing as employers limit benefits and employees pay more in lost wages. I'll come back with a quote that I like that nails that down in a bit. And then small business can't afford to cover their employees. And 88% of all businesses are on Main Street and are small businesses. and then you think, well, of course, COVID and millions of jobs that were shortchanged or wiped out during COVID aren't likely to come back, with some being replaced by robots. The whole future of work is kind of up in the air. But then this is a study 3 years ago that found how in 2018, how unstable employer-sponsored health insurance is. Then that year, 66 million Americans left or lost their jobs that year, with many not regaining insurance in another job. So this is really unstable, and even employers are looking at not being able to afford it. And small business hasn't been able to for a long time. So next slide. Oh yeah, here's the quote I was getting to. Here's Atul Gawande. He's a neurosurgeon, author of Being Mortal, Medicine and What Matters in the End. He says it very interesting. The central error of our system has been attaching our healthcare to where we work. A company-sponsored insurance plan for a family adds an average of $15,000 to the annual cost of employing a worker, effectively levying a 50% tax on a $15 an hour position. We're all but paying employers to outsource or automate people's jobs. The result is to make both work and healthcare less secure and more fragmented, and to deepen our inequality. So that says it pretty clearly. Next slide. Well, then privatization. You probably haven't seen this before. I hadn't until a few months ago. The revenues
You want to watch something?
of Medicare and Medicaid
This is on my schedule.
are
I
huge.
know, I said I thought you were busy until.
And they really, and this shows how their revenues keep
It's on the calendar. But I
No,
can-
keep them afloat, even though they're private. So now we're moving to what we can do about it. And you'll see these tables in the book, but we have 3 basic alternatives now. Build on the ACA, which Biden has said he wants to do. He's also mentioned lowering the eligibility for Medicare down to 60. He mentions a public option a little bit, but not much now, and Medicare for all. And by the way, as you probably read, Bernie Sanders and
Maya.
and Pramila Jayapal have agreed right now, for now, not to put Medicare for all front burner. So it's back burner right now as this debate comes along. Anyhow, back to building on the ACA. It'll never give us full access. It won't give us full choice. We'll still have insurance networks that are restrictive, et cetera, et cetera. If it ever would do anything for cost containment, 11 years tells us they haven't, not at all. Quality of care, not much good, not a concern. Nothing in that bill makes good quality. Bureaucracy is huge and wasteful. Universal coverage, never. Accountability, no. Sustainability, no. So, and then public option. Well, the ACA did set up like 23 co-ops with the idea that, okay, here's your not-for-profit insurance company, and let's see if you can compete with the others. And they have failed in 10 years. There were 23 of them set up, and all but 3 are dead. Anyhow, so the same lower thing, will never get cost containment, blah, blah, blah. Medicare for all, unrestricted access, unrestricted choice. Yes, cost containment. We can come back to that. Quality care improved because people have access. Bureaucracy much less. Bureaucracy of traditional Medicare is about 2%, maybe max 2.5%. We'd probably do Medicare for all for 2%, but the average private insurers, big ones, those are 18 to 20%. Universal coverage write-off, accountability, yes. Sustainability, yes. I can mention, I was in practice in Mount Shasta, California in 1965 when Medicare and Medicaid were passed. I was there 6 years in practice before going into teaching. And it was absolute seamless to see a patient that a few days after that was passed. Medicare card, Medicaid, you don't have to ask them what your insurance is. You ask, how can I help you today? Today, as we know, spend a lot of time on your insurance before you can even be seen in the office. Next slide. Okay, now here's a comparison of these three alternatives based on values. If we say healthcare is a human right, then it's obvious it's the third option. If we say it's a commodity for sale and we say no, we have to be Medicare for all. If we go with a service ethic, it's the same. If we go on medical need versus ability to pay, it's the same. If we want full choice of physician and hospital and other provider, other facility, it's yes. Access, reliable and efficient, yes. Not-for-profit, reduced waste, yes. Population-based shared risk, yes. Science-based, yes. Common good, public interest, yes. So next slide. Okay, who are the winners and losers? With Medicare for all, everyone in the country, physicians and other health professionals, yes. And physicians more and more, as like 2/3 are employed by others now and under the gun with trying to please their employers with being more productive, like more revenue and up coding. More physicians all the time are in favor of Medicare for all. In hospitals, especially those that are safety net hospitals or in urban underserved areas, they will do much better. Employers will do much better. Mental health care has been denigrated all along, and public health equally underinvested in, they'll do better. Federal and state governments will do better, and taxpayers will do a lot better. So who loses? Private health insurers, corporate middlemen, corporate stakeholders, privatized Medicare and Medicaid, displaced workers, and lobbyists. But displaced workers, the bill that we had in last year, HR 1384 in the House, remember, that actually set up quite a bit of money for the next 5 years to retrain displaced workers from the private insurance industry. So next slide. Okay, here's Ed Friedman wrote a very good book. You should read it. He's done at least 10 years now. He's an economist at UMass Amherst. And this is the slide that tells us how much we will save when we go to Medicare for All. We'll save in provider administration because we don't have to deal with multi-system insurers and that. And we'll, with Medicare for All, we can reduce on a fee scale negotiated rates with providers, and insurance administration will be much simpler. But and in the book, you'll see the exact numbers. They don't show up here too well, but anyhow, by his analysis, he says, if we had had Medicare for All in 2019, we would have saved more than $1 trillion a year in that year. So he nails all this down. It's very impressive. UMass Amherst and the group down at UC Berkeley, Zuckman and Sayes, they write in there as well on the same wavelength. So next slide. Well, this is our last slide. Phil Caper is an internist. He was in health policy and in DC a lot in the 70s and 80s. And Peter Arno, similar as interns as well. But they wrote this book, or this is a blog, but very important, Medicare for All, the social transformation of US healthcare. That's worth reading for sure. But here's where they bottom out. We're always, the political forces back a long way now, as you see in the book, force us to take an incremental step. But here's how they say it. The real struggle for a universal single payer system in the US is not technical or economic, but almost entirely political. Retaining anything resembling the status quo is the least disruptive and therefore politically easier route. Unfortunately, it's also the least effective route to attack the underlying pathology of American healthcare, corporatism run amok. Adopting the easiest route will do nothing more than kick the can down the road and will require repeatedly revisiting the deficiencies in our healthcare system until we get it right. And of course, you know what Churchill said long time ago about the Americans. They'll finally get it right after they exhaust all the alternatives. So I think I'll stop there and open for questions. Yeah.
John, I this is Dale, and I have a question. In looking at the provider, you alluded to the diminished number of primary care physicians coming out of residency. When I went back to my 50th med school reunion in 2016 and talked to the medical students there, the tuition at the medical school was $54,000 a year. And so you have these kids ending 4 years of medical school with $216,000. I'm sure it's higher than that now. And when I was in practicing in the recruiting committee of our organization, the questions that we were getting from the people we were recruiting, and this was around 2007, 8, thereabouts. They always want to know how much. These are the first questions: how much am I going to get paid?
Right.
How much do I have to be on call, and how much time do I have off?
Right.
And so here are these people coming with this incredible debt, many of whom don't want to take on the kind of well, responsibilities of being a primary care physician, and they're motivated more by money than the kinds of things at least I went into medicine for, that is serving others. And so my point is that it's a real struggle to be able to generate the kind of physicians that go back to that service model when in fact they're so much in debt and motivated by making money to pay that debt off.
All true, and that's a real discouragement to everyone in primary care and psychiatry and geriatrics and that. However, if we really reform our system, if we develop a physician workforce plan, if we revise medical education in favor of that plan for more primary care, other countries can. Why can't we? I know in Canada, they've had a problem, I gather, in Ontario 10 years ago or something, and they changed the reimbursement, made it much better, and their recruitment problems went down, and they've done better. So I think it is soluble, but we've got to change the system. The system, as at present, it's wiping out primary care. It's wiping out public health. It's just not a good system. So we got to rise up.
So this is Jim Squire. I just want to make a couple of comments and tell John where I think the whole movement is just not going in the right direction for Medicare for all. I think I might be the only person here. I know when I used to be on the PNHP Washington board, I was the only physician actually in practice. I don't think there's any practicing practitioners in this audience, nurses, PAs. So anyway, I'm still in practice. I'm 77 years old. I'm still have a small practice, and I can say without any doubt, everything continues to get worse and worse every year. And the private insurance system is just falling apart at the seams. I mean, right now, the vast majority of the money that I bring in is actually from cash, because even people who have private insurance, the deductibles are so high, I just make individual arrangements with them. It's more cost effective for them just to pay me cash at a lower rate, and they don't even use their insurance. And they just use the insurance to get the medication that I prescribe, but they don't actually pay me that way. And I don't take Medicare and Medicaid because I couldn't survive on that. So those people pay cash. So actually, more than half of my income even is just cash between me and the patient. I mean, the whole private system is like falling apart. The other thing is, it's just amazing to me. You could get through your whole talk without mentioning capitalism. I know you had that little thing at the end, the statement by Phil Caper and Peter Arno, which kind of was getting to that. But I always think about Martin Luther King, basically his analysis of what's wrong with this country, and it's basically racism, militarism, and capitalism out of control. And I think mostly what you're talking about is the capitalism out of control with regard to Medicare for all. But I think Medicare for all, to win it, it really has to be a revolutionary movement. It has to relate to the racism and the militarism, all the other major problems, and Medicare for all. People want to get that, they're going to have to work on the other things too and work with other organizations in these other areas. Otherwise, I don't think you have a chance of actually of winning it. And it's a much, much bigger, more difficult, obviously, undertaking. But I think it's reached a point where you have to, I mean, you were talking about, you know, the system is wrong, but the whole system is wrong in so many areas. And you have to work on them all. I don't think you can be an organization anymore that just fights for one thing. You know, just fights for Medicare for all as a single issue organization. I just don't think you can do that anymore.
Well, that,
Well, you know, I
Yeah.
kind of agree with a lot of what you're saying, Jim. I will ditto some of what you're saying. Really important.
Okay, thank you. Interesting presentation, very, very valuable to hear what an outline of your book, Dr. Geyman. Thank you for presenting that. You know, as you may know, here in Washington State, we have the Universal Healthcare Commission that was just set up, and it passed into law. It's being set up now, but that they have built into their deliberations is the stipulation that not incremental, but there are things that can be done right now, and they're not requiring that the commission can actually do things in a regulatory manner and not in a law, not by law, not through legislation for now, that will improve the situation for patients and residents of Washington State. So I wonder, on the national level, can that kind of approach be done in pieces so that you're not passing the whole enchilada of Medicare for all at once, but working toward it by, for example, working on physician allocation, making some kind of a regulation or some arrangement where primary care doctors are prioritized in education, and maybe their expenses for their education can be reimbursed or lowered somehow if they do these take positions that are that need to be filled but are having difficulty being filled. And so to get the pieces in place, start building the system in pieces, and then eventually it'll all be one seamless whole. But to start smaller, because I agree that it is really hard to get a big system change, especially when you have the insurance industry, health insurance industry, and their lobbyists that are so profitable and so strong in their lobbying efforts. So this is really, it's just the scale of the change is really daunting the more I think about it and learn about the role of insurance and how they don't care how much things cost, because the more things cost, more procedures cost, the more they get to make because they keep a percentage of everything. There was a great talk by Dr. David Belk, who's done a lot of research into insurance billing and medical billing, and you know the problem that there's no accountability. There's nobody knows what the true cost of these procedures are because they're hidden. And so you can't really have a market. We all know that already, but it's because the system is opaque. And why is it opaque? Because it's in the interests of the insurance companies to keep it that way, because they can, it's a very involved problem. And I can't go into it any longer here because I don't want to take everybody's time, but very interesting. And at Healthcare for All, we'll have a link to the recording of that presentation that was presented last month at our public meeting, and we'll have that up soon, and we'll distribute that to everybody. But yeah, so basically I wonder that in Washington State, we're doing bits and pieces as we can, while also building toward a universally funded and administered program here in Washington State. So how can that be done nationally?
Well, quick response. I think it's great what states are doing as here and building momentum towards what we're all after. However, I worry, and it's been tried already in Vermont, and the governor killed it at the end, I guess, and it's been tried in California and still an effort there. But to get a hold of all the funds out of public programs from different agencies in DC, Medicare, Medicaid, and others, you would need to bring all those to bear in your own state. And these agencies don't talk to each other, and they're not about to start. So that is a big worry I have. Back to the other comment, thank you, from New York State. We can't look at Medicare for All campaigning just as a single subject, but certainly it's got areas like racism. Racism we've had for hundreds of years. We have it in our healthcare system. I just learned the other day that someone looked at the major medical journals in this country, including New England Journal and JAMA and others. If you mention the word racism in your paper, that's down the tube. We don't want that. And they looked at hundreds and hundreds of papers, thousands maybe. So we have systemic racism, and the inequities and disparities in our present system are just huge. And look at what COVID did. So anyhow, racism could be combined into Medicare for All as another part of it, fighting racism.
So Steve, and then Hugh.
So I do think there's been a change at PNHP nationally, frankly, mirroring one that's been much longer standing in the New York Metro chapter, where we have very much been in active solidarity with groups working on a whole bunch of other issues, including anti-racism. And so we've been very commingled with the groups, with all the other issues here in New York. And I think, frankly, there's been a change in the national organization as well in that direction. I did want to bring forward, because I thought it was going to be something John was going to be emphasizing more as sort of the new thing, and I'm sure it's in the book. But I would suggest we've actually lost a lot of ground on the for-profit privatization. We've gone from private, for-profit, investor-owned hospitals, but at least their business was still ostensibly healthcare, right? It was a for-profit hospital. It's gotten worse because you have another layer away from actual healthcare with the takeover of private equity. So these are the same firms that, instead of being the for-profit toy company, Toys R Us, and then it gets taken over by private equity, and they basically destroy the company for parts. Because they're not actually interested in selling toys anymore. We have the equivalent going on in terms of additional layers of private equity in the healthcare system that's made it worse. I mean, as bad as healthcare, Corporation of America, for-profit hospital was, take another step back of it just being private equity playing with spreadsheets, and it's that much worse. The only good news is there is some fight back on monopoly capitalism and finance capitalism. And I've dropped some links in for two organizations, two sort of beltway advocacy organizations that do this as what they do, with healthcare just being a subset, as well as a really good newsletter called Acute Condition by one of their staff people. And also I've been collecting links for about 2 years now on the issue of the private equity issue. Don McCann did, I think, some 2 or 3 of his quote of the days before retirement on it over the last couple of years.
Yeah.
But I dropped the link in there for a Google Doc on that. But I think we've actually lost ground in one sense. I also want to make a comment about the kids nowadays. The kids nowadays, get off my lawn. The kids nowadays, in many ways, have a higher level, thanks to SNAP and PNHP and things like that. I would suggest they have a higher level of support for a single payer and principal coming out of med school than we've ever had before. And certainly my experience with them in New York has been they have organizational skills like we never had at their age. So I would really make sure that, I would strongly encourage folks to either work with your SNAP chapters or help SNAP chapters form wherever you are. I'm afraid it's after 11 and past my bedtime here. But thank you for letting me in to your space.
Well, I'd like to respond briefly.
Yeah.
Your point on private equity is very well taken, and I emphasize that actually in the book. I couldn't go into that much here, but it's in there big time, and it's a huge threat. And yes, the formula is to buy a nursing home or buy a dermatology practice or buy this other practice and get it much more into debt and then sell it at very, in 5 years, 5, 6, 7 years, or even sooner than 5. So that's the deliberate thing all the way. But they take the quality down and they just clean it out for what revenues they can. No, it's really bad. And now private equities are even looking at medical and information. We don't need them in there. And the thing I'm starting to read about now is telehealth. I mean, this should be an asset to a practice, carefully used, but it should not be a revenue producer. And so now the Walmarts of the world are talking about getting big time into telehealth. And what's that do to primary care, by the way? So all that.
So folks that are interested in this, every single one you just mentioned, there's been a recent really good in-depth reporting on in that newsletter, Acute Condition by Olivia Webb that I dropped in the chat. So I urge folks, take a look at it and consider it's a freebie. You don't need to pay money. I've also been dropped the collection of links I've got on some of these issues into the chat. Thank you, John. I'm just waiting for delivery on the book. It's already ordered. See you.
Okay, Hugh.
Thanks. John, thank you. That was an excellent book. And before I forget, greetings to Matt, and Amy, and Ben, former soccer buddy of my son.
Right.
The book was fantastic. Couple of things. I just finished having a visit with my graduating fourth-year students, of which I have 5 or 6 every year as their mentor. They are all, at least in a public institution, $200,000 or more in debt on average. And that drives their specialty choice. So that's one thing. In either, I can't remember if it was McDermott or Conyers' bill, there was a stipulation in there for a National Health Service Corps where as an alternative to military service, you could sign up for an embellished U.S. Health Service Corps for loan forgiveness. Those programs are a fraction of what they used to be, and they're really not that practical. So I think that's one thing that hopefully, as Medicare for All and Pramila Jayapal's bill, 1976, gets passed, I hope there's stipulations in there to address this pipeline, because we really do need long-range planning to develop better primary care. I was in London about 8 years ago, watching my son row, and I picked up the local rag, and in there it said, well, you're moving to London, you're going back to university, here's your checklist. Number one on the checklist was establish care with a primary care provider. And I thought, wow, what a great societal priority that is, which we don't have in our country. And all of your points about the fact that people get high priced care, but my nephew goes in with perforated, but he actually had Campylobacter, as it turned out, horrible diarrhea and shaking chills. And I said, you got to go get a CT scan. Being a surgeon, of course, I thought he had a pelvic abscess with a ruptured appendicitis, but they said, follow up with your primary care provider. Well, he's 35 years old. He doesn't have a primary care provider. And it took me a half day of work with my inside connections to help identify him to find a primary care provider. And he has, quote, top shelf insurance. The other thing I really enjoyed about your book was mental health care. Mental health care in this country, for all practical purposes, doesn't exist. I had several family members with significant psychiatric acute issues, young people. And even with top shelf insurance, it was a thrash to get them help. I've had neighbors go off the rails, and the only way that they got help was for it to escalate to a police activity. So I think mental health care and long-term care in nursing homes are two of the most florid examples of where our, quote, system is failing people drastically. Not only that, but in all manifestations of the whole thing. I think I agree with Jim. I think that the young people are very motivated. Even orthopedic residents in a survey done in our institution said that they would be happy to volunteer for a year or two and go overseas if necessary in an embellished U.S. Health Service Corps, akin to what they do in Cuba, in order for loan forgiveness. So this indentured servitude that U.S. medical graduates leave medical school with, number one, drives their specialty choice. Number two, makes them have to sign on now. I started looking up. So CHA Franciscan is a big deal here in the Northwest. I started to look at who owns those guys. Well, they're conglomerated now with another group of, I forget what the name of it is, they have over 1,000 different facilities now in the Northwest. And Ascension Care out of Chicago is another huge conglomerate. So this increased consolidation, this working for, a lot of us worked for corporations. I worked for UW Medicine because I didn't believe in private practice myself and wanted to be devoid of that. But all of those things drive our current medical school graduates, who are altruistic people, into this system of indentured servitude that's impossible to break. And I think Medicare for all, with stipulations for long-term planning, allocation of specialty choice, like they do in other countries, is the only way out of this horrible conundrum, not to mention the whole care issue. So long diatribe, but thank you so much, John. This was a wonderful work. And I'm so glad that my wife left today and gave me the time so I could sit down and finish your book. So hats off to you for all your help and dedication.
Great to see you, Hugh.
Okay, Margaret?
Hey, thanks all you doctors. I'm
Betty
speaking a
next.
little slang here, but can you hear me?
Yes,
Betty next.
I'm speaking a little slang here. How long are they going to get away with, like Kittitas Valley Hospital, when I went in for my colonoscopy, I signed, I am the responsible person, the person responsible. I actually signed a blank check to them. And and now they're chasing me down 3 years later for $500 that Medicare won't pay. And I said, how many colonoscopies do you do a year? don't you know how much it's going to cost? You know, can't somebody come in and say, oh, yeah, I want to call out colonoscopy. Okay, you say, I'll pay the $5,700 or whatever. Anyway, that's just what's irking me today. And how long are they going to get away with it? I think there's some legislation about billing transparency somewhere. Thank you. Thank you, everybody.
It's being lobbied heavily against.
John, when I went back to getting back to my reunion
Yes.
6 years ago, a very high percentage of graduates from medical school at that institution had dual degrees. And the dual degrees were MD and MBA. And the focus was in the medical school, getting business programs to the medical students, as if that was the focus that they should be addressing in their professional life, in addition to becoming a physician.
Mhm.
And that was a bit disturbing to me. And I don't know how other medical schools are pursuing that as well, but if that's what they're teaching the young people, to focus on the economics as opposed to the ethical and service philosophy that we ourselves developed when we became doctors, it makes it very, very difficult with the new generations of physicians.
One, I really thank you so much, John. This has been wonderful. I always love to hear you and to be a part of your exposés. I also want to say, please say hello to Emily. I think she remembers me. I remember her. She's
There
lovely.
she is right here.
And you are so lucky to have her. Hi, Emily. That's my first thing.
Okay.
So hello, and so one thing a couple things I want to comment on. First is this issue that I think someone brought up about incrementalism, like we have to take it one step at a time. Well, we've been taking this one step at a time since after World War II.
Right.
And we're done with that.
Right.
Or we should be. If we're not done with that, there's something wrong with us.
Right.
So incrementalism, and in 2009, before the Obamacare Act was passed, people said, well, we better go with that because we know we need single payer, Medicare for all, but we will do it incrementally. We got Obamacare, and essentially, except for the one issue, at least for me, is the preconditions before you, not preconditions. What is it called? Help me.
Pre-existing conditions.
Pre-existing conditions. Thank you.
Yeah.
Except for that,
Right.
that bill was not what we needed.
Right.
And people went with that and said, well, we better go with what we can get. That was 2009.
Yep.
We are these many years past that. And I'm still hearing from people, including people who support state universal plans, which are not single payer plans, does not cover all the United States, especially the states that are so backwards and so racist that they didn't even embrace the Obama Medicare, enhancement. They didn't even do that. So really, I want to say to my colleagues on this call, we should all be putting all of our energy into Medicare for all, universally, nationally. We should not be doing what the states are doing. We should not be doing what Washington State is doing, because basically what they're doing is jerking us around. First, you have a commission to study the question, then you have another commission to study the question, and you end up with mush, as a friend of mine calls it. So people need to get away from that. And then my third point, which really connects, so I got two more points. A few months ago, there was a movement called hashtag Force the Vote. And what we were asking is to push the so-called progressives in the Congress, at least the few on the squad, to push for a vote around Medicare for all. And it wasn't because we thought we're crazy that we're going to get Medicare for all. It was to push the question, have a debate that would help better inform, increase the information for the people in the United States. And that's what we wanted to happen. It was no illusion that we would get a bill passed, 1384 or whatever. And we didn't have any support by the Democrats, by the squad, by any of the so-called progressives in the Congress to do this. So I just heard, John, you said this. I didn't know this, but I suspected this, is that both Sanders and Jayapal, the author of 1384,
Right.
had agreed to put Medicare for all on the back burner. Well, that is ludicrous. When we need it the most, we've gone through COVID, we're going through COVID. Are we going to let them get away with that? People, we have to do something. Our organizations are supposed to be leaders in this. And I'm sorry I'm going on, but I really have to go on because I am really upset with us to continue to accept less than what we all deserve and pushing for the people in this country. Incrementalism should be dead. We should not be accepting that. And John, my question to you in my final thing is, what does it mean that Sanders and Jayapal, who are the people we look to support the things we believe in, the thing we believe in, Medicare for all, agreeing to put this issue on the back burner? Help me here.
I'm not sure, except maybe we need HR 1 and a Voting Rights Act and get rid of the filibuster, as first things. We really got to get rid of the filibuster. And I hope the Dems can stand up and get that done. So it might be just timing wise for Sanders and Jayapal, though I don't know, but I hope it's just that.
Yes, and so I just want to respond. Yeah, I understand. But people should be able to do multitask. These people are elected by us. They should be able to focus more. They should be able to focus on HR 1, which is very important.
Right.
We should definitely get rid of the filibuster. They should be the Democrats should have gotten rid of the filibuster on day one. That is what's holding up everything.
I agree.
That's right. I mean, we have to.
Yeah.
People on this call, if you attach yourself to the Democratic Party, that's screwing us every single time on every single issue, they're going to continue to do that. And they're going to lose.
Okay.
So I'll stop there.
Mindy?
I'm really upset. I'm upset.
I was encouraged by the recent yesterday winning of Larry Krassner in the Democratic primary in Philadelphia for district attorney on a very, very radical platform. And even despite the fact that there were forces arrayed against him, including the Democratic Party, I think, was supporting a different candidate, and he still won because there was a movement to support what he was standing for. And I guess what I'm feeling is that we might need to generate some kind of thing like that, because I don't think we're getting anywhere. And I guess I wonder what other people might think about that, how to move this thing forward, because we've been like treading water for decades.
I think there is a possibility of good incrementalism, and there's definitely bad incrementalism. So I think good incrementalism could move us forward if it eliminates the private insurance industry. And there are some, bills out there that are seeking to do that. And also, I think that we can work on the state level and the national level. Of course, national is primary, but we're picking up tons of activists who are working on the state level. And I think we're bringing them into the Improved Medicare for All movement. And I see that in Washington State, where I've been working with Healthcare as a Human Right. Washington, I've met so many other people. They're not, rabid Medicare for all people. They all agree that that's the best way to go, but they're also willing to, say that bad incrementalism would still leave some private insurance industry in the mix in there. So, but if you look at PNHP chapters around the country, California, New York City Metro, Minnesota, they're all working at both levels, at the state level and at the national level. Of course, national level again is first. But this brings up the question about, we got something going on here, the quote Universal Healthcare Commission in Washington State, and the one-payer states describe this as the most important single-payer legislation in this country, which is, I don't think many of us would believe in. I believe that's true, but there is something in there that they want to have a universal financing system, and including the possibility of single payer, which at least, is a possibility to fight for that part of it. So anyway, what I'm saying is, I think we can't just focus our, everything we're doing on Medicare for all at the national level. We have to build our movement of movements with, like somebody was saying, that we need to do, work with groups that are working on some of these other social determinants of health, which I think the Healthcare for All Washington, or Residents Healthcare is a Human Right Washington, is many of the groups in there are looking at other things. Anyway.
I would like to just stick in one thing. Somebody mentioned that journals like the New England Journal of Medicine won't publish anything that says anything about racism. That is not true. That was true at a time when nobody in medicine was facing up the possibility of racism. But they've recently had practically a whole issue devoted to talking about various aspects of racism and social determinants of health. So they're learning too.
So John, what is your take on working at the state level as well as the national level?
I think we need to do both, but we need federal legislation for sure. If efforts at the state level can help us move nationally, that's great. But it'll be hard to get single payer in a state, I think, where what do you do with Medicare and Medicaid and et cetera, et cetera.
Well, you have to get federal cooperation in one form or another. That's clear.
Well, one payer state is focusing on Ro Khanna's bill, which is going to be introduced June 1st, supposedly. So take a look at that.
I would like to add to what Betty said. We're in the middle of a pandemic. The need for Medicare for all has never been more present than today.
Right.
A vast majority of the American public is in support of Medicare for all. A majority of physicians are in support, or in healthcare providers in general are in support of Medicare for all. we just don't have, what PNHP has been lacking is a legislative strategy to attain it. Now, Betty mentioned the hashtag force the vote issue. That was a decent strategy, I thought. But there was no backing from any of the left-wing organizations that support Medicare for all. I just don't quite understand that. I'm just unclear on why PNHP National is not developing what could be a legislative strategy to achieving what most people want. It's kind of flabbergasting. And it's been like that for a long time. I mean, most people have been supportive of Medicare for all, even before the pandemic, but it's increased since the pandemic started. So I'm just curious, John, what you think. By the way, I appreciate the book that just came out. I haven't started reading it yet, but thank you so much for writing. Your books are just great. I'm curious as what you think, what kind of strategies we could use legislatively, because we're going to have a legislative strategy to achieve it somehow or another. It's going to have to go through Congress. It gets signed by the president. What strategy should PNHP be pushing for?
Well, I like your ideas, and let me come at that a couple of ways. Number one, yeah, COVID showed how crummy a system we have, and we had lots of profiteering, and that's in the book too, even during the pandemic, by drug companies, by across the board. So we're coming across a real obvious need. Disparities are terrible out of that. And so that could be a political wedge, I would think, if we build upon that. I tend to think in primary care, it should be the foundation of our system. And we, I just read a thing today out of the National Academies of Science, Engineering, and Medicine. It used to be Institute of Medicine. Institute of Medicine did a big report about the urgent need for primary care. That was in 1996. They just come up with a brand new one from this engineering, science, engineering, and medicine. And they call primary care, it's slowly dying. They talk about it. Okay, so let me come around now to a new development in the last year. A coalition of the primary care specialties, internal medicine, pediatrics, family medicine, coalition of 400,000 primary care docs in this country. First time this coalition, the base of primary care in this country, and they're all for Medicare for all. So things like that, we've got to keep putting these things together and building political strength. Yeah, I'm no expert on the legislative strategies, but I agree, we've got to build our strength and convert impetus from states into national.
Hi there. Generally speaking, I'm not in favor of incrementalism, but when you spoke, David, of positive incrementalism, I would say the most effective thing we can do is to support, I believe it's Sanders and others in the Congress who want to lower Medicare eligibility age qualification from, say, 65 to 50. And I'll tell you why that's, I think, the most effective legislative strategy. One, how many people of 65 and older who have Medicare would dump their Medicare and pick up private insurance if they could afford it? How many would do it? The odds are very few, because in the surveys that I looked at, and my information is all about 10, 12 years old, most Medicare recipients are very happy with their care. I'm not speaking about Medicare Advantage necessarily, but they're happy with their care for the most part. So here you are. You're looking for a legislative strategy. You lower the age to 50. That brings in an age group of 50 to 65. Guess what happens? Those people tend to be active voters. When those people experience Medicare, they're not going to dump it, and they're going to support Medicare for all. And they're going to relate to their electeds how satisfied they are with their care. If you're looking to win over voters, you start where you can make a difference. The big question, and this is a question perhaps John can answer. You know, we got Medicare in part in 1965 because the insurance companies didn't want to insure old people because they were a liability. They cost too much. The big question is, if major efforts were put into insuring people 50 to 65, would we get the same pushback from private insurance to protect that age group? That's the unknown, because I think maybe if they make all their money in that age group, that's different. But if they don't, if basically they are a loss leader, perhaps, maybe we have a shot at getting the 50 to 65-year-olds. And once we have those, the incrementalism would come maybe 5 years later and lowering it to 45 or to 40. And I can see that being a much more viable strategy than changing the system radically, and nipping it along, and improving along the edges. We've all seen that. We're tired of that. But that's how we win patients to the system. That's how we win voters. And we have to win over voters to change our governance. And I'll stop there.
Well, that's an interesting idea, and I think it might be effective. I mean, we really don't know, but it might be down to 50. That gets most people. Really, that would build a huge political force.
Mm-hmm.
I think that's a good strategy of lowering the age, but I think we have the voters already. I don't think we need to convince them that Medicare is for all is the best way to go.
Well, we do need improved Medicare for all with, the vision and dental, all that,
Yeah.
which is in Pramila's bill, and that's the one dissatisfaction with Medicare, is that it only covers actually about 50% of your expenses.
Well, that's primarily what we refer to as Medicare for all, is improved Medicare for all.
Yeah.
We all agree with that.
Right, but if we're going to incrementally expand it and keep the 50 to 65-year-olds happy, we're going to have it include dental care and prescriptions,
Right.
and also lower some of the cost sharing. Medicare has no ceiling on its cost sharing.
Right. I mean, if you have Medicare without a supplement in many settings, you're considered to be Medicaid, and you will be easily declared out of network by many providers. So, I agree with Dana. I mean, the elephant in the living room is the pandemic. I mean, we are under something that's not happened in over 100 years in this country. And we have the majority of the voters behind us. We have more than 100 U.S. representatives behind us. And, Larry Krassner, well, he's doing good because somebody in PBS decided to do a series on him. So what we need for Medicare for all is we need a good PR group to help get this issue out in front of the American people, because unless the tragedy of our current non-system washes up on your doorstep and you go bankrupt, which usually takes about 6 months before you realize it's happened, it's not a reality. It's just not. And so people can kick that can down their road because they got so much else to worry about. But I think a mass movement, this is the time, and we need to strike, and we need to Get it out in front of the press.
Can I'd like to speak about mass movement a little bit, because I feel like that's sort of what I'm trying to work on. As I mentioned, I'm leading a march for Medicare for All on July 24th. And that's a movement across the country. There are marches in DC, LA, San Francisco. I know there are some folks planning in Portland as well. And I want to also talk a little bit about, we've talked about different kinds of incrementalism, and passing statewide is a type of incrementalism. So is lowering the age eligibility is another form of incrementalism. And I think it is going to take a mass movement. And one thing that I think is powerful about the state-based approach is we can build that mass movement by having 50 state-based approaches. And of course, they need to mutually support each other and also mutually support a national campaign as well. But that's how you actually can build movements in every state to create enough pressure on every member of Congress to work nationally. And the other thing about running statewide campaigns together is that the insurance lobby then has to split its resources and fight in 50 different states. And the Republican Party never leaves the states behind. The Republican Party always fights at the state level. I was just reading an article today showing that the insurance companies were coming out with huge amounts of fundraising against statewide public options because they fight at every level. And so I think this fight needs to be a mass movement at every level. And so that's why I'm organizing these marches all across the country. And I work with statewide campaigns all across the country because we need to learn from each other's experiences and each other's mistakes. For instance, you talked a little bit about Vermont, right? Vermont was a campaign that failed in part because when it was passed, it didn't have its financing figured out. Whole Washington's bill has its financing sorted out. California, which everything I'm hearing from CalCare is that it will not pass at this time, did not have its financing sorted out. So, I think there needs to be more connection between these campaigns. They need to collaborate, they need to share resources, and they need to build their voices collectively, build their power collectively. And I think we can pass this across the entire country, like we saw with gay marriage, which was a state by state. Cannabis is going in that direction as well. And even healthcare in Canada started in a single province, and in 10 years had been expanded to the entire country. So I really want to see more collaboration. I would love to bring PNHP Washington into both the march and the ballot initiative, which is collecting signatures between now and December, and they need to collect about 400,000. And it's an all hands on deck type of situation. So we would love to really organize with you, to build coalition with you, and to get this thing done. Because I do think that we could be the first state to pass it. I do think the first state will be the hardest. But I also think that once we pass it in one state, it will be inevitable. So, I really appreciate the work that all of you do. And I just hope that we can find more ways to work together.
Where is the march going to be from to?
Yeah, so the march is about 2 months away, and we're still working on the route. I have a team that meets weekly. And so if anyone is interested in being on that team, you can get in touch with me. It's open to everybody. And yeah, the main thing is I do want to, I want to have some consideration about the route because I want to make sure it is accessible to the disabled community. So I want to think about that and make sure that it's something that, reasonably a lot of that community can participate in.
It isn't just people who are disabled. There are some of us who are old and can't march all that far, even though we're not officially disabled, and especially hills matter.
Absolutely. Yeah, so, it will be in Seattle. I want us to spend some time thinking about the route carefully. But I want this to be a really, really inclusive action. I want it to be really unifying. And so, and I want it to be bigger than just even the healthcare organizations, right? So I want to reach out to other activist groups, because that's part of building a mass movement, right? Is seeing how these issues are related to each other and building that power together. So, so yeah, I really want to continue this conversation, and I'm open to whichever way that works best for all of you.
Well, start by keeping us at PNHP Washington informed on how it's going.
Yeah, we have a June meeting. You can give us an update on it.
Absolutely.
Okay.
Yeah, Andre, you
It
mentioned
sounds
that.
great. I mean, the thing that you're saying, it just sounds really optimistic and really good to me. I really think it's a good thing. And I just want to say, I don't think that the PBS program about Larry Krassner, I mean, he won by a landslide because he was promoting things that people supported, and because there's no electoral college to obstruct his votes. I mean, he just won because he had good ideas that people supported. And I think we have the support of the mass population. It's just that, we have elected officials that are obstructionist.
Well, they're paid to be that way. They're paid by their campaign contributions.
Yeah,
Unfortunately.
Andre, you mentioned at the start that this would be a support for Medicare for all on a national level, I believe, this March. So that's going to be the primary message that we will be carrying.
I think it's designed to be a little bit more inclusive than that. I think it is a march for Medicare for all. And, we want that to be, I think, to put it a little bit more clearly, I think we've had discussions about, what kind of speakers we'd like to have and that sort of thing. And, we'd like to avoid people who are talking about ACA expansion or public options. But basically, we know that there are many different organizations doing a lot of different strategies and a lot of different kinds of work. And I think we want to create something, a banner that sort of they all can come out together on and mutually appreciate and respect each other's work and organize together. I think we're trying to really bring everyone out. So, the banner that we're going with is March for Medicare for All.
Well, John, would you and Emily come on down to Seattle for such a march?
You could put a banner on your plane and fly above the march.
Flyover, yeah.
Maybe so.
One of those advertising banners trailing behind.
Yeah. Well, lots of great ideas, and in this group, it's been a pleasure to be here, and so much energy and good ideas in this group.
Right.
Well, we meet monthly, and we're always, would be wonderful to have your wisdom.
Many of our ideas come from you.
Yeah.
That's right.
You produce Bibles that are references that we can go to whenever to find whatever we need to buttress our arguments.
Yeah.
So you've done an amazing job every year bringing it up to date.
Yes, and you can always, during this time that we're all meeting virtually anyway, you can always join us at our monthly meetings. Well, of course, PNHP Washington does not maintain a lobbyist in the other Washington. And I don't know what the current status is of PNHP National. Do you, David, or John Geyman, do you know?
I think there's about 5 people that work out of the national office in Chicago. I don't think there's a lobbyist in DC like Margaret was at one point. Most of our local organizations that are working on single payer are trying to lobby our representatives, meeting with them on Zoom. And Healthcare is a Human Right Washington has set up lobbying with the district representatives to try to get them to support Pramila's bill.
Right, and I'm proud to say that my representative, Adam Smith, is signed on to the current Medicare for All in the current Congress, where it's HR 1976.
Right.
It's all because of me, right?
Group of us meeting with Kim Schreier in a couple of weeks too. So a
That's
whole
right.
consortium of people are going to be meeting with Kim. And as you know, Kim is not signed on as a supporter yet. She is a pediatrician, but she also is the heir apparent to the Dave Reichert, somewhat conservative, carefully gerrymandered district. We'll be up pushing her, steady, gentle pressure, continuous, gentle, but continuous pressure.
And who knows what that district is going to look like after redistricting. At least we have a relatively nonpartisan approach to redistricting in our state. Anything else? Thank
Great
you,
job,
everybody.
John.
And
Nice
Bye,
to
everybody.
look forward to hearing more about the march.
So I'll be putting this thing on YouTube in a couple of days. So, and I'll try to break it down by chapters or topics. So
Thanks,
Thank you,
David, for
John.
putting this on, and Sherry.
Thank you, John.
Thank you so much, John.
Night, John.
Thank
Night.
you all.
Thank you,
Okay.
Ciao.
Night.
Night, everybody.
Bye,
Bye.
everybody.
Night.